Greetings and welcome. I am Angelique McKoy, licensed clinical professional counselor in the state of Maryland, here to talk to you today about creating trauma-informed care environments. Let's get to it. So if I've done my job correctly today, you will first have a better understanding of trauma-informed care as part of a biblical approach to clinical care. Then we're going to talk about trauma and define it through a clinical and a real world lens. We're also going to explore trauma and how it affects the brain, how it affects the functioning of the brain, and ultimately the behaviors that you are probably seeing in your client spaces. And lastly, we are going to walk through the four-pronged approach, 4 steps to creating a trauma-informed care environment, hopefully making your practices more smooth, more applicable to the work, and more trauma sensitive. Let's jump in. So, why is trauma informed care such an important part of the Christian lens to treatment? It's because we want to really understand all of the facets that are happening in our faith based communities. And that includes the psychological, it includes the social, it includes the emotional, it also includes all of the trauma that our clients may be walking through at a moment at any given time. When you're thinking about trauma informed care, it's emphasizing active listening. And I know that's something that we do in our daily practices, but it's also allowing individuals who have experienced trauma to express their own needs, to be able to share and articulate their own feelings in a place that is clearly without judgment. We know that that is part of the person centered care, to involve the client without judgment. Also, when we're in our clinical spaces, it's important that we maximize re-traumatization. And we're going to talk about that a little bit later by being sensitive to those individual experiences, understanding that we are avoiding immediate actions that might re-traumatize our clients or questions that could ultimately cause further harm. And ultimately, we are providing support for our victim survivors, or as if you are an advocate in the space or you are a service provider in the clinical space. And most importantly, trauma informed care is an important part of the Christian aspect of care because it empowers individuals to seek help. How often have we been in our faith based circles where talking about mental health struggles is taboo? Or it's a conversation that is not held. And so this empowers individuals to seek available resources. So, what comes to mind when you hear the word trauma? I'll give you a moment to think about it. But I can imagine some of the words that are coming to your mind could be associated with therapy, with psychiatric need. If you are someone who really enjoys digging deep into the therapeutic work, it might be the DSM. It could be thinking about events that have happened to people, thinking about the stressors that are a part of everyday life that then exacerbate us. It could be something emotional. You might even be thinking about a specific trauma, like maybe violence, sexual assault, child abuse, something that happened in the developmental stages. But there are so many different facets to trauma. There's even intergenerational and historical that we could go on and on and on, thinking about how it happens in an incident, how it happens sometimes we are witnesses and not the exact persons that are experiencing it. But trauma is an important part of this conversation today. So let's jump in a little bit further. Let's define trauma. The American Psychological Association says that trauma is an emotional response to a terrible event, such as a crime, could be an accident that you witness, could be a natural disaster, or even a physical or emotional level of abuse. There's neglect, experiencing or witnessing violence. One that we don't often talk about is the death of a loved one. Grief is a form of trauma, of course, war, and there are more aspects to trauma, which leads us to believe that it's not just a once incident that we can just put into a box. But now that we know what it is, what does it look like? And I really appreciate SAMHSA's definition, which is the Substance Abuse and Mental Health Services Administration, which we will refer later on in this presentation. But SAMHSA defines trauma as individually resulting from an event, a series of events, a set of circumstances that happens, that has been experienced by an individual as physically or emotionally harmful or even life-threatening, that has, and this is the important part, that has lasting adverse effects on the individual's functioning, whether it's their mental, their psychological, their physical, their social, emotional, or spiritual well-being. So trauma can affect all the parts of who we are and cause us to walk through the world differently. There are three types of trauma that those in our field are typically encountered with, and that would be acute trauma, which is isolated. It's usually one event, such as you are in or you witness a car accident. Maybe there's an incidence of school violence or even a natural disaster, which happens once and then it's done. And then the next level would be chronic trauma, which is repeated and prolonged over time. And it's prolonged exposure. For example, think about a child bullying, civil unrest, which we have gone through and continue with this political climate, as well as even intimate partner violence. And then there's complex trauma. And complex trauma is chronic. It is persistent. It is usually something that has started in childhood and has continued throughout that individual's life. For example, childhood sexual abuse, neglect, and domestic violence, which is different from intimate partner violence. And this is just helping us to understand the intersectionality of trauma, that it can happen to anyone at any time, and that my perception of trauma and your perception of trauma are both subjective, meaning that it is not determined by what we have gone through. It is an individualized occurrence. And so the intersectionality means that our identities are always overlapping. I am a Black woman. I am a spiritual and deeply religious Christian woman. I speak English. I am of a certain age. So there are definitely many aspects of my intersectionality that can connect with others, but at the same time, they are overlapping. So we cannot just say that one particular race only experiences trauma, one particular age group only experiences this type of trauma, one religion only experiences this type of trauma. Audre Lorde said that there is no such thing as a single issue struggle because we do not live single issue lives. So as you're walking into your clinical spaces, this is a reminder that everyone experiences trauma differently. So therefore it will manifest itself differently, which means that your skill set has to be varied in efforts to treat that particular trauma. So what does the brain have to do with all of this? And we've been walking through trauma-informed care, and now we need to stop and think about behaviors and actions. And that's where the brain comes in. So when we're responding to someone who is experiencing any levels of trauma, there is a concept of working from the bottom up. Give you a second to write that down. In your trauma spaces, work from the bottom up as it pertains to the brain function. We start with the brainstem, which is where that client is coming in with their survival state. This is typically when you are working with someone who is in heightened arousal, their amygdala is in full capacity. They are trying to regulate their fight, flight, freeze, and sometimes fawn responses. And so in this space, we have to first help them to self-regulate, help them to find the safety within the treatment room before we can even move to the emotional state, which is housed in the limbic part of our brain, which is right up underneath. And so when you think about the limbic system, it's the area of our brain that helps us to relate and connect. It helps us to be able to feel the feelings and to articulate the feelings and to begin to understand the feelings. So until you have provided a level of safety in your trauma spaces and your therapeutic rooms, you will not be able to relate with that individual, to be able to validate their feelings as what should be happening during this time, letting them know that you see them, they are safe, that they are able to unpack these things in a place where they can connect and move forward. Then and only then can we work from the top. Remember, we're working from the bottom up. And the top is the cortical brain, which is where all of our executive functioning lives. And that's our cognitive state. In this place is where you can begin to reason with your client in the therapeutic work, and you begin to support them by helping them reflect, by asking those open-ended questions, by moving them towards a place of curiosity about their situation and their trauma, helping them to learn. This is where the psychoeducation will really, really be able to rest well. And so you're articulating to help them become more self-assured. So remember, when you're working with your clients from the bottom up, you must first make them safe in that survival state through the work of the brainstem, helping them move to the emotional state where they can begin to relate with what is happening. And that's that limbic system. And lastly, reasoning in the therapeutic world through the cortical brain, which is that cognitive state. Our surroundings, our emotions, and our thoughts. That is how you're able to effectively move through working with someone who is experiencing trauma. So, what does trauma informed care have to do with all of this? And then where does it come in? We now understand the concepts. And so, where does it come into the work? It comes in because it is an approach. Trauma informed care, which has been a buzzword over the last 10 or so years, not even 10, maybe right after COVID. Trauma-informed care is an approach that assumes that an individual is more likely than not to have a history of trauma. So you're going into your workspaces. And of course, as therapists and as counselors and as Christian counselors, any area that you are in, we are already assuming that trauma is a part of the work, because that's why people typically come for counseling, to move through spaces in their lives that have been challenging. But trauma-informed care really recognizes that we have all experienced something. You may have heard of the ACEs study, the adverse child experiences. And if we all take that test, we all walk with at least one or more of an adverse child experience. So imagine carrying those into adulthood. So trauma-informed care as an approach to your work recognizes the presence of trauma symptoms. It acknowledges the role that trauma plays in an individual's life. So you know that your clients are going to come to you, sometimes not wanting to open up, sometimes not wanting to speak, sometimes not wanting to have the therapeutic tools thrust upon them. And then what you're doing with this approach is that you're including it in every aspect of your work. So if you are in private practice, it is in your policies and your procedures and how you function. If you are in an organization, those who are making decisions are looking at ways to engage clients at every aspect with a trauma-informed care lens. And so what do organizations look like that are trauma-informed? They look like places where services are viewed through the lens of trauma. Safe spaces. I acknowledge that you have gone through some things. And so I, as your counselor, in whatever capacity that you're watching today with this video, that you will understand that you need to handle that person in a way that they have gone through something very traumatic. Organizations that implement trauma-informed care also look at their policies, and they eliminate policies and practices that might traumatize or even re-traumatize. And I'm talking everything from language in your intake forms. I'm talking about not using first-person language. For example, a person who is experiencing trauma as opposed to a traumatized person, a person who has been raped as opposed to a rape victim, a person who is living with whatever the case may be. And even if you're working with someone who may have been abusive, instead of calling them an abuser or a batterer, it may be someone who uses abuse in their relationship. And so thinking about how your policies and your practices not only protect you in the work, but also don't re-traumatize individuals so that your space can be fully active and open for you to do what it is that you've been called to do in this work. And then another way that trauma-informed care organizations look different is because it's an ongoing process. It's not just here's a policy, we're done, and we move on. But creating that trauma-informed care agency or organization or practice, however you want to call it, it's fluid. It's ever moving. It's ever growing, it's ever evolving, because the ultimate goal is to meet the needs of the individuals you serve who have history of trauma. And that will change from client to client. There are no two clients that are experiencing the same thing, even if they have the same diagnoses. It is not exhibiting the same. The symptomology is not the same. And so we need to be able to be fluid and less rigid in our thought process of how we build trauma-informed care spaces. Hope this is helping someone. So let's look at SAMHSA's framework. So SAMHSA has a framework that was originated as a response to natural disasters. And after COVID and all of the facets that came with a changing landscape, the world shutting down, people having to be in their homes, children going from in-person school to computer school, and all of those things, SAMHSA reevaluated. And what I love is being a trauma-informed agency, reevaluating the policies and the processes that they already had in place. And so the 4 R's of trauma-informed care are realize, recognize, respond, and resist re-traumatization. The easy way to remember them is that they are 4 R's. I'll say it again: realize, recognize, respond, and resist traumatization. And you will have access to this presentation, or during this time, hopefully you're taking a quick screenshot. And so let's briefly look at all 4 and see how they are interconnected, and also how to weave them into your work. First, we need to realize, as practitioners in this faith-based space, we need to realize the widespread impact of trauma. And not only that, but understand the paths of recovery. We know that the Bible tells us that, Christ went through the traumatic event of the crucifixion so that we could be free. The scripture says that the chastisement of his peace was upon him, and with his stripes we are healed. So we are realizing the impact of trauma, but also understanding different paths to recovery. Again, trauma spaces will look different depending on your client. Their roads to recovery, their treatment plans, their therapeutic goals will all look different, because they would be significantly tied to that individual's personal account. And so how do we understand the potential paths of recovery for our clients? We make them a part of the process. It's not our job just to go in and build a treatment plan sight unseen, but it's a conversation with your client. What is it you would like to achieve? How do we think we can get there? Are the conversations that you will start to have. And so once you realize, then you're able to move to the next R, which is recognize. Recognize the signs and the symptoms of trauma in your clients, in their families, if you're in an organizational setting, even in the staff that you work with, and all of those that are involved in your work system. Recognizing is such a big responsibility, because it means that you have to always be aware. And so those of us that are in the clinical space and that are direct counseling, we understand that we are always needing to be aware of what's happening, not only in the space with our clients, but if they are reaching out outside of the client space, when we are doing documentation, what is showing up differently from session to session. And even if we are doing family systems work, I myself work with a lot of children and their families as well as adults. And so that family systems work is important, because the whole family is seen as the client. And so what does all of that individual functioning look like to become a collective understanding of what you need to recognize in that client and their responses? And so once you've been able to realize the widespread of trauma and understand the different paths of recovery through your treatment goals, and now you're recognizing what signs and symptoms look like. Today, my client is withdrawn. The last time I saw them, they were overly emotional, and this time they might be really wanting to dig in. Signs and symptoms, what does it look like from session to session? Once you're able to do those 2 things, then and only then can you respond. And often we try to respond right away, And we move past realizing and recognizing, and we move straight to action. And I applaud all of us who want to be active and go right to the work. But if we follow the steps in the order, we'll have better success. And so responding is when you are fully integrated into the knowledge and the trauma policies that are going on in your organization, the procedures that are in your practice, and everything that you are doing to make sure that your clients have what they need. What does your collaboration look like? Do you work with any other providers? Do you work with any other resources that you're referring? What does that look like in terms of soft handoffs? Are others dealing with your clients in the same fashion that you are? Because that's what a trauma-informed care collaborative looks like. And then once you have recognized, and once you have once you have realized, and then you have recognized, and then you have responded, then and only then do you walk circumspectly and make sure that you are resisting re-traumatization, specifically of children who are prone to be more resilient, but also the effects last longer, as well as the adults who care for them. So when you're thinking about re-traumatization, are we revisiting things that don't necessarily need to be revisited in this session? Could this be something that we wait for a closing session, or could it be a closing activity, or could it even be homework? With me bringing this thing up in this client state right now, will it help or will it hinder? And yes, in our work, we do press a little bit and we do challenge as we should, and we do help our clients move to a place where they are actualizing their best selves. And we need to do it in the timing that works with that client's capacity. And so again, the 4 R's to implementing a trauma-informed care lens into your work are realize, recognize, respond, and re-traumatize, and do not re-traumatize. So I know you're wondering, after our time together, how can you make a difference? And I want to stop here and say, I'm pretty sure you're already making a difference, because you're in this conference finding and learning ways to become an even better practitioner. And so I applaud you and I honor you for the time that you've given me today to pull on your ear. But you know how you can make a difference? Just take care not to re-traumatize, not to replicate pains that your clients are going through. We never want to be the trigger. We might want to stimulate our clients' thoughts and stimulate the emotional healing process. But what we don't want to do is to not understand the effect that these things will have on our clients' feelings and behavior while they are processing. So understanding trauma and applying those trauma-informed responses really helps us as professionals increase the likelihood of success. We want to be successful in our therapeutic spaces. We want to look back and see clients that we have discharged in a positive light, not because they stopped showing up, but because they transitioned. They graduated to a different level of care where they are able to utilize the coping skills and move through trauma to the other side. So in our last few moments together, I would love for us to have some time to process. And so when you see this traffic light, automatically you think of being in a car or riding in a car or driving a car, and you come to an impasse where you have to make some decisions. The red light means stop. We know that. The yellow light, depending on what city you live in and how you drive, it could mean go a little faster because I'm about to approach a stop, or it could mean yield. I'm going to slow down and really think some things through before I move forward. Green, we know all is clear. We're doing what we need to be doing. Let's keep it moving. And so in these few moments of planning time, if you have paper and pen available, I would love for you to think through areas in your practice now where maybe there isn't the trauma-informed care lens that you would want it to be, or you've learned a little bit more and you want to figure out how to apply that. So let's start with green and write down the word green, and After green, I want you to write down everything that you feel is going well, that you're doing to its fullest capacity, where you are seeing successful rates of healing and efficacy with your clients, where your treatment plans are effective and all the things are working, and there is trauma-informed care work happening under your purview. Kudos. I want you to congratulate yourselves. I want you to enjoy the moment. I want you to savor the opportunities that God has given you to help people and be a guide in the journey to wholeness and wellness. And so now I want you to write down yellow. And after yellow, I want you to write down the words yield and put a question mark. What is it you need to yield? What do you need to maybe slow down because you're moving so fast that you're not seeing the results that you want to see? Maybe think of a specific client that you've been moving in a specific way with the treatment plan and you just have not been actualizing any progress. What might I need to do different? Ask yourself, am I moving in a trauma-informed care lens with this individual? Am I in the session becoming the trigger? Am I possibly re-traumatizing this person? What do I need to do differently? Maybe there's some things that I've said today that maybe you need to do some deeper research for yourself and really figure out if this is something that you can do. But yield means to slow down, to almost come to a complete stop while you are re-strategizing. I've been in practice for quite some time now, and there are times when I have to intentionally stop what I'm doing and really just take a sabbatical briefly to make sure not only am I recharging, but that I am providing the best practice lens to my clients. I'm giving them the best me, that I am doing my professional development, that I am understanding what I need to do, how I need to do it, and that I'm getting the insight that I need from my colleagues in order to be the best clinician that I can be. And then now I want you to write down red. So you should have green, you should have yellow. Now I want you to write down red. And next to red, I want you to write in really big letters, stop. I don't know what the stop might be. That's up to you to determine. Are there things you know without a shadow of a doubt that if I switch how I am doing this, things will change? If I go back to my textbooks or my professional development resources and my Bible and my colleagues and those who are helping to pour into me, if I stop and go back, what will make me a better clinician? We all have areas that we need to hone up on. We all have areas where we need to grow a little bit more. We can be in this practice for decades, and because of the changing trends and the lens of therapy from now until in the past, and even how it's moving in the future, some of us are telehealth professionals and never thought that we would be interacting and engaging with folks through an internet space, but hello, good afternoon or good morning, wherever you are. We are now doing just that, even with this workshop. What do I need to stop so that I can, again, this is all with the goal of being the best practitioner that you can possibly be. So I encourage you to take some time during the conference and think about your strategies. Celebrate what you are doing well. Pause and make some intentional conversation with yourself around what you could be doing differently and what might be a switch in direction in terms of your therapeutic practice. And also think through things that you should not be doing, things that have not been successful, things that have been tried, things that the data is showing you that it is not working, and look to the areas where you need to stop. It is planning time. We are better when we plan. And so before I leave you today, I want to talk to you kind of about just the takeaways, the things that we've talked through today. We've been together for just about 30 minutes, and I hope that this has been a fruitful 30 minutes for you. And so one of the takeaways is that as faith-based communities, and I am so godly grateful for this conference, faith-based communities have a biblical responsibility to operate through a trauma-informed care lens. Our work should model that of Christ, who was the chief counselor, the chief teacher, the master teacher, who said, "Suffer the little children to come unto me, for such is the kingdom of heaven." Arms were always open. And in our therapeutic spaces, as faith-based counselors, we have a biblical responsibility to move as the arms and the legs of Christ on earth, not to be Christ in the treatment room, but to be an advocate for Christ and to share the word coupled with the therapeutic skills that we have all gained from our educational endeavors. We have a responsibility to do that in this work. And then we're also supposed to realize the value, understanding that it is important to infuse trauma-informed care approaches into your way of doing business. It will make your business better. It will make your services more applicable to the populations that you serve. You can tailor it specifically for individuals as well as for communities. It will make your work more attractive. It will help with marketing that you are trauma informed and that you are actually doing it. It will increase the amount of visualization and the amount of clients that you have if you are doing business in this way. And so it will also help to occur changes at other levels of your organization. If you are not the chief decision maker, having these conversations all the way up the chain to the top means that changes will occur. And so there needs to be buy-in from every level of your organization. Conversations about trauma-informed care, lastly, need to be happening on a regular basis. That last bullet talks about you need to be the one leading. You've been in a workshop that talks about the importance of trauma-informed care. And so, like the Bible says, we're not supposed to hide our light under a bushel, but we're supposed to tell someone else, communicate about it. Talk about it in your staff meetings. Talk about it to your leadership. Get training on trauma-informed care. Right now, there is a plethora of tools out there. There are dissertations that are written on the importance of trauma-informed care, especially in the clinical church, mine included. You can get it after June, and it will help you to really understand that transformation is a part of this work. And so leading the conversations is the takeaway that I want to give to you. And so before we go, I'm going to stop sharing my screen and get rid of the slides and just talk to you for a moment, practitioner to practitioner. I hope that this has been useful. I pray that this has been helpful. I pray that from this conference that you will take all the tools that you have received, that you have learned, and soak them in, kind of like we soak a bread in a bowl of gravy, and that we will become sponges for learning and for professional development so that we can be better practitioners in our practical therapeutic spaces. I hope that you have a sweet conference, that everything that you need, you get in these next few days. And thank you for joining me. I have been Angelique McKoy, and this was Creating Trauma-Informed Care Environments. Take good care.